Okay, well, it looks like we have a quorum. Welcome, everyone. This is, I think, the 15th installation of the West Coast Fellows Conference. Appreciate everyone being here earlier in the morning. Really excited today because we have David Yang with us from the University of Colorado, who is going to discuss predictive modeling and data and how we can use that to improve reliability in our outcomes. I've known David maybe for 2 years or so now and consider him a friend. And I know that he has a huge impact on the training of the residents at Colorado. Originally from Minnesota, though, right, David?
Correct.
So I'm sure that you're happy to be a little bit further south with better weather. And before I turn the screen over to you, I did just want to put in a quick plug for the Bridging the Gap meeting, which will be down here in Southern California towards the end of July, and it's sort of the official meeting of the West Coast Fellows Conference. And there are some funding options that'll probably be available for fellows to travel to the conference. And we'll have some more information about that as we get a little bit closer. So without further ado, David, I'm going to stop sharing my screen and turn it over to you. And thank you in advance.
Thanks, Hani, and thanks everybody for joining today. See if I can get this to work. Can everybody see this okay?
Yeah, we can see it.
Perfect. Yeah, Hani, I actually just came back from Minnesota. I was shoveling snow for my mom, and they'd gotten 8 inches of snow, and now my back is destroyed. So that was awesome. Just another reason not to be there.
The irony is not lost.
Yeah. Thanks everybody for being here today. This talk is a little bit of a departure from our more recent and excellent West Coast Fellows Conference talks in that it's not really didactic and it's more of a practical commentary. It's also not a true AI talk or a Farhan Police or Chris Ames data analytics level talk. This is really a personal account of how one might use data that pertains to their historic performance to improve their reliability and maybe their skill set. And I think that's particularly important for the people in this audience because there are a lot of fellows, there are a lot of residents who are transitioning the practice, and it's easy to think that everything that you're learning in fellowship right now is going to carry over very easily and immediately into your practice, and that's not always the case. And I think we oftentimes forget how much struggle your mentors go through to develop the skill set that they have and become as prolific as they are. So this is just one tool that you might add to your armamentarium to flatten that learning curve when you start. Here are my disclosures. So when I started my practice, or about 2.5 years in, I had just passed my boards, and I was trying to figure out what my role in the division, in the department at the University of Colorado was going to be. And I quickly realized that, I don't know if CJ Kleck is on, but he basically recruited me to do complex spine and deformity with him because he wanted me to share in the misery of taking care of all those complications that are associated with the surgeries. And so for better or for worse, I decided that I needed to become a deformity surgeon and a complex spine surgeon. And I went to the SRS meeting and I attended a breakout session on the appropriate approaches to deformity correction. And Larry Lenke was advocating for posterior approach. Manish Gupta was an advocate for anterior posterior approach, and Juan Uribe was the advocate for lateral approaches. And they each showed a number of cases, and their results were spectacular. And at the end of the breakout session, they concluded that there isn't a right way to do deformity correction, and any approach was appropriate. But I was frustrated. I went home frustrated because I wasn't confident that I could achieve the corrections that they were achieving with any of the approaches that they had advocated for. So I decided that I needed to get better quickly. I need to get better at deformity. And when you're in practice, you'll start to realize that, the resources that are available for you to improve and the way you improve becomes a lot less obvious than when you're in fellowship where somebody tells you exactly what you need to work on. And one way to improve is to do another fellowship. But when you're in practice for 2 to 3 years, it's very difficult to leave what you're trying to build to do another fellowship. That's very disruptive. You can go to industry-sponsored courses, and we know a lot of those are hit or miss. You can go to a lot of conferences, which most of us do, and learn from people who are experts in the field, but you'll quickly realize that their skill sets are oftentimes very different from yours. And then you can read a lot of papers, which I certainly was doing. But the problem with a lot of the spine research is highlighted in this meme. And one of them, probably my favorite, is that one at the bottom that says, "I'm a great surgeon, really great," which essentially is the paper which shows a surgeon who does a study and advocates for a certain technique, but for some reason you can't seem to replicate his results in your own practice. one of the problems that I was having wasn't so much using these techniques to improve, but rather figuring out exactly what my skill set was to begin with. And this is a picture of Peter Drucker. Peter Drucker he's now passed away, but he is a famous U.S. management consultant. And for right or wrong, he's credited with coining the phrase, "What gets measured gets managed." And I knew I had to measure outcomes to figure out what my skill set was, not what somebody told me my skill set was and what I was good at, but objectively speaking, what I was capable of doing. And what I really wanted to measure were my patient-reported outcomes. And I also wanted to I wanted to measure functional outcome scores. But the infrastructure at my institution at the time didn't allow me to do so consistently or reliably. So the one thing I did know that I could measure were radiographic outcomes. And we had a partnership with a technology that allowed me to plan my surgeries, plan my corrections, create patient-specific rods after simulating that correction, and then measure my radiographic outcomes at whatever cadence I decided to obtain post-operative x-rays. So I decided at that point that for a year at least, I was going to dedicate or plan every single one of my multi-level fusions in this platform. And after a year, I had some data. Now, this isn't a collection of University of Colorado data. This is my practice. These are all of my patients. So this is internally validated for my practice. And in that year, I did 91 multi-level fusion cases, and 40% of those were considered adult spinal deformity cases. And so I had some data, and what I was measuring was, from a regional alignment standpoint, PI-LL mismatch. From a global alignment standpoint, I was measuring SVA, and I was also measuring pelvic tilt and thoracic kyphosis to, evaluate changes in compensatory mechanisms. And at this point, we're far more sophisticated. We're evaluating maybe 25 radiographic parameters, L1PA instead of PI-LL, for example. I see Mike Kelly's on there, and he talks about that a lot. But this is what I have data for, and this is what I have comparative data for. So in terms of PI-LL mismatch, what I found is that preoperatively, the average PI-LL mismatch as highlighted in red was 8.2, and postoperatively, meaning what I achieved, is highlighted in green, which is 2.5. And for all practical purposes, a PI-LL mismatch on average of 2.5 isn't terrible. It's very reasonable. But what bothered me was the discrepancy between my planned PI-LL mismatch was negative 2.6 and my post-op value of 2.5. And that discrepancy was essentially 5 degrees, and I thought that was unacceptable and could be improved. When I looked at pelvic tilt, the discrepancy between my plan and actual values was 0.1 degrees, and I thought that was actually very reliable. Now, I can't take credit for this. Superficially, it may look like I'm good at predicting what happens to compensatory pelvic retroversion after the surgery, but the truth is I was using a predictive model to guess what this would be after my surgeries, and it showed that the incorporation of the predictive model was appropriate and that the model was pretty accurate. When I looked at global alignment, SVA, the discrepancy between my plan and my actual value was about 3 centimeters. Again, the average SVA was 3.5 centimeters, which would be considered reasonable in an independent case, but the discrepancy is what bothered me, and I felt like I could improve that. For thoracic kyphosis, that discrepancy was 2 degrees. Again, very reasonable. That had nothing to do with my skill set. I was incorporating a predictive model that was pretty accurate at the time. So this data alone immediately showed me there was room for improvement, specifically in achieving my regional alignment parameter metrics, as well as achieving my global alignment parameter metrics or targets as measured by SVA. But it didn't really tell me exactly how to do so. So I started looking at specific surgeries that I was doing and the segmental correction that I was achieving with each of these surgeries, starting with interbody fusions. I started with doing T-lifts 44% of the time, A-lifts 31% of the time, and O-lifts about 25% of the time. And on average, I was shooting for just over 3 degrees of correction. You'll see in green here that on average, I achieved about just under 3 degrees of correction. So, in general or superficially, it looks like that type of surgery was very reliable for me. The discrepancy between my plan and my actual corrections was about 0.4 degrees. And this is without any sort of posterior column osteotomy, just with the interbody technique. When I took a deep dive into this, I found that T-lifts were very reliable. I was getting about 2.7 degrees of correction on average without a posterior column osteotomy and achieving almost exactly that on average. So at this point, I felt like T-lifts were a very reliable surgery for me. A-lifts, on the other hand, were very unreliable. I was shooting for about 4.7 degrees of correction on average, but really only achieving 2 degrees of correction for a discrepancy of about 3.2 degrees. So I knew that I needed to improve my ability to perform A-lifts. And when I looked at specific levels for A-lifts, I found that my problem wasn't at 3.4 or 4.5. but at 5.1. I was very bad at achieving the correction that I was shooting for at 5.1. And I'll explain why in a little bit. I also looked at O-lifts. I had a few of these that weren't accompanied by some sort of posterior column osteotomy. Superficially, it looked like I was achieving about the correction that I wanted to with a discrepancy of 0.5 degrees on average. But when I looked at SPOs or Smith-Peterson osteotomies, I found that I was pretty unreliable. I was shooting for about 8.2 degrees of correction on average, but only achieving about 4.6, and that discrepancy was about 3.5 degrees. So I knew I needed to improve this technique. I'd done most of my PSOs at the time as a co-surgeon with one of my senior partners. I did a number by myself, but I didn't think I could draw any meaningful conclusions from this. Overall, it looked like maybe I was overcorrecting slightly, but I needed to collect more data here. So at this point, I took a step back and I thought, what was working well? The first thing that was working well were T-lifts. I felt like T-lifts were a reliable surgery for me. I was achieving, on average, exactly the correction that I was shooting for. So I decided, if this is a skill set that I possess, I should probably leverage this. So I decided to be more aggressive with my T-lifts, maybe shooting for more than 3 degrees of correction on average. And then to do so, I decided to incorporate expandable technology. So that was the first change that I made to my practice. O-lifts, I think I needed to collect more information. I didn't think I could draw any meaningful conclusions from the data, so I didn't make any changes there. I knew the predictive models were working well, so I was going to continue to incorporate those the same way that I had been. And the jury was still out as to whether or not PSOs were a reliable deformity correction surgery for me. In terms of what needed improvement, I knew that A-lifts needed to be improved, specifically A-lifts at the L5S1 level. And when I looked at, or I did a critical evaluation of how I was performing that surgery, I realized 3 things. The first was I was not being vigilant about evaluating the degree of interbody lordosis that was there preoperatively. We all know that if you have 14 degrees of interbody lordosis to begin with, if I select a 10-degree interbody cage, I'm going to lose lordosis, very likely, at least. And if I wanted to correct, I probably should shoot for a more lordotic implant. That seems very obvious at this point, but for some reason at the time, I was placing implants such that they fit from a tactile standpoint rather than being judicious about the implant I chose to get the correction that I wanted. The other thing that I realized is that the implant that I was using had very limited lordotic options. In fact, the most lordotic option that they had was 14 degrees, and sometimes I needed 16, 18, or 20 degrees. And the last thing I noticed that for this technique was that the implant that I was using had a 4 divergent screw construct anteriorly, which is very robust and very rigid. The problem with this is that when I was doing these procedures, if I did not achieve the correction I wanted with the anterior procedure alone, this construct was so robust that I had difficulty achieving more correction posteriorly with posterior instrumentation. This is an example of one of my partner's cases where he placed 2 A-lifts, and with posterior instrumentation, he achieved almost 22 degrees of correction at the L4-5 level. But because the anterior instrumentation was so rigid, there was a lot of strain placed on this construct, and the set screw disengaged from the tulip head, and he lost about 10 degrees of lordosis, and we had to go back in and instrument this bilaterally and fix it. So those 3 things were probably the reason I wasn't achieving the correction that I wanted at the L5S1 level, and I decided I needed to change my implant to one with more lordotic options. And in cases where I didn't achieve the correction that I wanted with the anterior procedure alone, I would only instrument either proximally or distally and not both, so that I could achieve more correction posteriorly. And I also became really vigilant, hyper-vigilant almost, evaluating the interbody lordosis preoperatively and the flexibility on flexion extension films if I had them available. For posterior column osteotomies, I also noticed 3 things. The first was that, just like in A-lifts, I wasn't being judicious about which levels I was choosing to correct through with this technique, and oftentimes I was picking spondylotic levels that you really couldn't reasonably expect mobility through if you did facetectomies alone. So I became more judicious about which levels to use this technique for. I became more aggressive with the facetectomy and decompressions that I was doing to achieve the corrections that I wanted, and I decided to attenuate my expectations for how much correction I thought I could get with this technique. I was shooting for just over 8 degrees on average, and certainly in spondylotic levels in the thoracic spine, getting 8 degrees of correction through that interbody space would be optimistic to say the least. So I made those 3 changes, and changes in these 3 areas of my practice, in my posterior column osteotomies, in A-lifts, as well as in T-lifts, I felt would help me better achieve my PILL targets that I was shooting for, as well as my global alignment target in SVA. I was shooting for a discrepancy in my PLL mismatch of less than 3 degrees, and I was shooting for a discrepancy in my SVA of less than 2 centimeters. So at this point, I went back to data collection. And for the next year and a half or 16 months or so, I did 142 more multi-level fusion cases. About 30% of them were adult spinal deformities. And when I looked at interbody fusions at this time, I found that I was being more aggressive. I was shooting for about 5 degrees of correction per level, but I was really still only achieving 3. And if you recall previously, before the first set of data that I had collected, I was only achieving 3 degrees of correction. So for all practical purposes, I didn't make any improvements in my ability to achieve correction through an interbody fusion. What I learned from this is that unless I planned to accompany that technique with some sort of posterior column osteotomy, in my hands, I was not going to get more than 3 degrees of correction on average. Certainly, there were segments that were very mobile that I could achieve more, but on average, I should be shooting for about 3 if I'm thinking about creating a plan that is very reliable. When I looked at the specific surgeries I was doing, I found that for A-lifts, specifically at L5S1, I had become very reliable. In fact, the discrepancy between my planned correction and my actual correction for A-lifts dropped to less than 0.5 degrees. But I actually got worse at T-lifts. Something that was previously very reliable became unreliable. And here's why. In my attempts to be more aggressive and achieve more correction in incorporating expandable technologies, like in this case where I had 22 degrees preoperatively and intraoperatively had around 26 degrees, I was expanding this space quite a bit. In fact, not just in lordosis, but also in height, which increases the stress through the interbody space. And I was seeing a lot of subsidence, and anecdotally, a lot more subsidence than I had previously. And so I decided at this point I needed to revert back to shooting for maybe less correction unless I was planning a posterior column osteotomy. And the cage that I was using, I decided to switch to one where the end plates of the cage matched the contours of the end plates in the interbody space better and expanded more in lordosis and less so in height so that I could decrease the strain within the interbody space and therefore decrease subsidence. And I'm still waiting to see if that is paying off. Anecdotally, I've seen less subsidence with the new implant and the new technique. When I looked at Smith-Peterson osteotomies, something that was previously very unreliable became very reliable for me. At this point, I was shooting for about 6.1 degrees of correction on average, and I was achieving 6.2 degrees of correction on average. So that discrepancy fell to about 0.1 degrees. So previously, that discrepancy was about 3.5 degrees, and now this is something that is very reliable for me. VCRs, I had done a few, but not enough to draw any meaningful conclusions. But I had done more PSOs as the primary surgeon. What I found is that on average, I was shooting for 22.2 degrees of correction and achieving 21.9. So that discrepancy between my plan and actual corrections was only 0.3 degrees. So something that's actually reliable. And how did that translate into my radiographic outcomes? Well, for regional alignment parameters, PI-LO mismatch specifically, the discrepancy between my plan and my actual values dropped to 3 degrees. And if you recall previously, that discrepancy was about 5 degrees, which seems like a very incremental improvement of only 2 degrees. But my contention is that if you make incremental improvement in multiple areas of your practice, it adds up and it becomes clinically meaningful. And proportionally, a 2-degree improvement is a 40% improvement in my ability to achieve my radiographic targets in terms of PI-LO mismatch. For pelvic tilt, that discrepancy remained low, it's 0.3 degrees. Again, credit to the predictive model that I was incorporating. This suggested that we were incorporating it correctly, and it was accurate. The same was true for thoracic kyphosis. That discrepancy was 1.6 degrees, well within the margin of error for a sagittal Cobb angle, again, suggesting that the predictive model was incorporated correctly or appropriately and that it was accurate. For SVA, that discrepancy dropped to 2 centimeters at this point. And again, this isn't the full story. There were some cases where I couldn't strictly follow the preoperative plan. For example, I had one patient where I had planned to do an L5 PSO and it failed to recognize their transitional anatomy. They had a Castelvi-Chan 2B with bilateral pseudoarticulations. And we had to abort the L5 PSO and instead did an L4 PSO. And there's certain cases where, we had to modify the plan slightly. Like we had to do Smith-Peterson osteotomy at a different level, for example, because of instrumentation failure. But when we did follow the plan strictly, the discrepancy between my planned correction and my actual corrections and my SVA dropped to 14 millimeters. Again, that seems like maybe an incremental improvement, but recall previously that discrepancy was 3 centimeters. And then proportionally, this amounts to over a 50% improvement in my ability to achieve SVA targets. So incremental changes, again, can amount to clinically meaningful changes if you make incremental changes in multiple areas in your practice. So again, looking at what was working at this point, O-lifts, stable, A-lifts, improved reliability significantly. The predictive models, still reliable. posterior column osteotomies or Smith-Peterson osteotomies, something that was very unreliable previously had become extremely reliable for me. And PSO, something that I wasn't sure how reliable I was at performing, turns out are very reliable for me. So this list of techniques that are reliable for me and things that I can use in my deformity correction surgeries have become very reliable is growing. In contrast, things that I thought were reliable previously, in attempts to leverage that skill set and maybe aim for more correction per segment, I became unreliable. And that's the case for TLIF. I saw a lot of subsidence because I was being perhaps over aggressive when I was trying to achieve without sort of mobilizing the space and incorporating expandable technologies. And I've since reverted to shooting for 3 degrees, which seems to be the standard for me for an interbody technique, unless I plan to do a posterior column osteotomy where I can get anywhere from 7 to 11 degrees. And again, I've also changed the implant back to one where it expands more in lordosis and less so in height, hoping to decrease my subsidence rate. And the goal is, or the hope is, that leveraging this new skill set that I have, or reliable surgeries that I perform, along with the changes that I'm making to my TLIF technique, will result in more reliable matching of my planned PI-LL mismatch and my actual PI-LL mismatch, and the same for SVA. I also finally had some data for PJK at this point. What I found is that using the criteria of greater than 10 degrees, my PJK rate was around 12 degrees, and PJF, or a criteria of greater than 20 degrees, around 3.7 degrees, which is in alignment with what is reported in literature. I will say anecdotally, as I've improved my ability to correct both in global and regional alignment, these numbers have probably increased slightly, but I'm still collecting data over the last 18 months or so to figure out if that's actually the case. So I hope that's a very practical, or highlights a very practical way that you can use your historic data to drive improvement and improve your skill set and maybe develop new skill sets. I think we talk about patient-specific planning and patient-specific implants, patient-specific surgery all the time, but very rarely or seldom do we talk about surgeon-specific planning and surgeon-specific surgeries. And I think we really need to. There's only, one Greg Mundis, or there's definitely only one Mike Kelly and only one CJ Kleck in the world, and not everybody can be those guys. And while they're leaders in our field and we should be learning everything that we can from them, your skill set will be different. And there are certain areas where you will be better and certain areas where you will be worse. And you should be leveraging your strengths while improving your weaknesses. And this does take some time and it does take some effort, but it was certainly enlightening for me. Knowing your data can make you more reliable in your practice, and I think it also will make you more confident as a surgeon. Thanks.
Thanks, David. I couldn't agree more. And I think, as a deformity surgeon, obviously you've gone through a lot of work to quantify, your outcomes. But I would just say for the fellows on the call, even if you're not a deformity surgeon, keeping track of your patients and your data, obviously it's important for boards collection. But even if you're just tracking complications or issues that you had with surgery in any kind of systematic way, it's going to give you a lot of power to iteratively improve. And obviously that's critical. So I'll open it up, and JC, it looks like you have your hand raised. So why don't you start?
Yeah, David, JC Levesque from Virginia Mason up in Seattle. This is really, I want to applaud you for being very honest with your journey here. I think, as you alluded to, there are many times, those of us who have been in the field for a while would give presentations on here's where you need to get to. But I think what you've done really nicely here is effectively lay out a training plan. It's like you're trying to run a marathon and these are the steps you need to go through. And I really appreciate your sort of iterative process improvement that you went through and deciding what worked and what didn't work and how you're going to adapt to that. And I think especially for the fellows, it's hard because many of you are training with people who are experts. And so it just looks like this is how it's done. And yet what you're not necessarily seeing is all the failures that went in to get to that point. So I think you have shown a very nice pathway of how one can go about understanding your own results and deciding what steps are within your control. And you have, particular skills that may not match someone else's, and learning how to leverage your skills to achieve the outcomes you desire.
Right, JC. That's exactly the point. I think, and CJ well. CJ and I discuss this a lot. we joke that he's the intuitive surgeon and I'm the non-intuitive surgeon. And by that, we mean he's very creative and he's able to achieve things based on his intuition that I'm not able to do. I need data and I need evidence to do something. And I'm meticulous about my approach to both the surgical procedure because that's the only way I can achieve the results that he achieves very intuitively, right? And so this is really just one method, and I think this resonates with a lot of people, but certainly it can work for everybody. And incorporating what you learn from conferences and literature that you read, industry courses and fellowship into using your data analytics is even more powerful.
Looks like Andrew Vivas from UCLA has a question as well. Andrew?
My close friends call me Andrew. But hey, David, I thought that was a fantastic talk. I think something that a lot of us struggle with, myself included, are figuring out how to quantify our results, our postoperative results. And really, I think the reliability of getting a patient to where they need to be and improving the patient-related outcomes it's something that obviously will improve as our skill sets improve, but this data feedback is critical. I was hoping that so I've run into some of the same issues that you have with having the institutional resources to quantify the patient-related outcome measures. And I was hoping that some of the faculty on here, maybe some of the senior guys, could offer some insight or some advice as to how they were able to start reproducibly following their patient-related outcome measures. Because I agree that the imaging is something that's there and something that we can mine and get a lot of valuable data. But of course, that's going to be only as reliable as the correlate to the patient-related outcome.
I can tell you how we did it at our institution, and it ended up being a department-wide partnership with the company. So I don't know how helpful that is, but there are certainly companies available who will track a lot of the patient-reported outcome metrics and for you. But there certainly is an expense. We pay a subscription fee to them per surgeon. But I think in this data-driven world that we're starting to transition into, your reimbursement is going to be linked to your patient-reported outcomes, and the contracts that you get from insurance companies will be linked to that as well. So you can certainly make a financial argument to your hospital, but there will definitely have to be a business plan presented to them for them to agree to acquire those services.
As a question that sort of piggybacks off of that, David, if here at Scripps we have good electronic patient-reported outcome tracking, but we don't necessarily have access to software that so sort of eloquently measures our planned and achieved correction. So I think that's potentially one area, if there was more of an open platform that will allow us to track those things. I don't know if you have any commentary on that. I'm assuming that you're using UniID for that data acquisition.
Yeah, so I use Unit, but there are other planning platforms. SurgiMap, obviously. There's NuVasive has Pulse. BrainLab has theirs. There's something called VertiPlan. And Don gave a talk a few months ago about some of the Carlsmed interbody implants. So you can certainly plan things in there. The truth is, I'm lucky. I'm lucky that we have this partnership with Medtronic and Unit, and that I can measure these things. And that I saw Vicky is on the call. That their team measures a lot of these things for me. If you don't have it, unfortunately, you will have to do this manually, and so the time commitment required to do so will increase dramatically. But I would still argue that it is worth doing so. The answer to that question is that I'm a little bit spoiled because I have that technology available.
Great. Well, it's 7:00. Does anybody have any additional questions, or any of the fellows, perhaps? Okay. Well, David, thank you.
Hanny.
Oh, sorry.
Hanny, just one last thing, just going off of David's statement. You're right that something like UNID really allows for, an assessment of many variables. I would urge each individual, even if you don't have access to something that measures quite so global a situation, to identify one or two items that you're going to go after. Whether that's, hey, I want to decide how much I'm actually getting at 5-1, or whether that's, I want to look at my 4-to-1 angles. I think that sometimes we believe if we can't have it all, that it's not worth doing. And I would say start somewhere.
Yeah. Yeah.
Right.
I think that's a very good note to end on, and definitely agree with you, JC. Well, it's 7:03. I know folks have to get to the OR. So thank you for logging on. I'll very quickly just plug our upcoming speakers. So we have two scheduled. The first in May will be Venkat Ganapathy from Arizona. So very much looking forward to that in May. And then in July, we have Adam Cantor, who recently made the move out west from Pittsburgh. So looking forward to that as well. And we're still trying to lock down June. So have a great day and a great weekend, and we'll see everybody next month.